in what we hope will be a series of webinars that will highlight innovative work of how partnerships serve to advance social justice and health equity. At the core of today's presentation are community engagement studios. This innovative work has gained the interest of many that are involved in community engaged research and practice. We're excited to join the Vanderbilt-based team as they share the key findings of the project, including the importance of storytelling and narratives as a means of community patient input, the diversity of ways that stakeholders contribute to research, and finally, a new quantitative scale to measure the person-centeredness of research. We're excited that you could join today's call and ask that you mute your phones. We will have a time of sharing questions and provide answers at the end of the session, and we'll start today. We want to also just let you know that we're working remotely, and so our team is in Vanderbilt, and I'm in North Carolina today. Just to let you know that this webinar is being recorded, and the slides will be available at the email, the website listed on your screen. There will be a series of speakers followed by a question and answer session at the end, and please use the chat box for questions and comments. We'll start today with our overview of our agenda. And our first speaker today will be Consuelo Wilkins, Dr. Consuelo Wilkins, from the Meharry-Vanderbilt Alliance.
Hello, everyone, and thank you for joining us today. And I want to give special thanks to Al and Community Campus Partnerships for Health for hosting the webinar today. It's been really my pleasure to serve as the principal investigator of this project. When we started in 2013 envisioning this, many of you are aware of how the field has emerged over the last few years, but our intent at that time was actually to test whether or not a model that we've developed here at Vanderbilt and Meharry, the Community Engagement Studio, would be effective in obtaining patient-centered input. Now, many of you are aware that with the emergence of patient-centered outcomes research, some people readily understand that this is a valuable method, will readily understand the importance of engaging communities and stakeholders in research. Unfortunately, though, this is not evidence-based. So we set out to demonstrate that through evidence by comparing our community engagement studio to a model that has also been developed here, and that's the translational studio. So we had three really goals for this project. One was to compare the effectiveness of the community engagement studio in obtaining patient-centered input. And really, to do this work, we had to develop some new tools. One is a taxonomy of changes that occur due to stakeholder engagement and research. The field has emerged some since we started this project, and there's more evidence supporting these changes, but there still isn't a taxonomy that exists to show these changes. And the third goal was to develop and validate a quantitative instrument to assess patient-centeredness. Again, something that is really important for the field, and making sure that we're able to assess engagement broadly as well as compared across studies. Next slide. So we have an amazing team who worked with us over the last several years on this project. First on the left, that's me, and Al and Yolanda are stakeholder investigators on the team. You'll hear later from Yvonne Jostin, who has led our community engagement studio model, and Ken Walston, who has led and guided us in the development of the quantitative scale. Lori Novak, who has led the qualitative analysis in helping to develop the taxonomy, along with Chris Simpson, followed by Tiffany Israel, who, along with Yvonne, have really helped to move our community engagement studio model and propel it to some national prominence. Leslie Boone, who has been critical in many aspects of the work. Margaret Hargraves and Velma Murray, faculty at Meharry and Vanderbilt respectively, have provided invaluable guidance for the project. And then key on our Meharry-Vanderbilt Alliance team, Mackenzie Houston, Sarah Stallings, and Elena Boyer, who is now at the National Healthcare for the Homeless Council. I think really important to this work, though, I want to make sure everyone is aware of how involved stakeholders have been in this project. So we've had 167 stakeholders involved. So Al and Yolanda have been key members of the team. They participate regularly in our team meetings. They have an equal voice at the table and have helped to steer this project along. They've been with us the entire 3 years of the project and have also been involved in doing some of the qualitative analysis. We've had 153 community members and patients who've been involved as experts in our community engagement studios. We've had community members and patients who served as interviewees and evaluators of our taxonomy. And we've also had 6 community members who served as abstract raters in testing our quantitative scale. Next slide. So our overall approach to this project was to randomize researchers who were seeking input for their projects to either a community engagement studio, you'll hear a little bit more about that method shortly, or a translational studio. The basic difference between these two is that the community engagement studios provide input or have experts that are patients or community members. Whereas the translational studios have experts who are researchers. Even though we randomized researchers, and that was a lot of fun, to one method or the other, the researchers were not actually the subjects. The subjects of our work were the transcripts that resulted from these studios. So we compared the elements of the transcripts from the community engagement studios to those of the translational studios, and we were looking for some patient-centered elements. And we'll also be rating those transcripts with our new quantitative tool. So Lori will tell you more about what the patient-centered elements look like and what we found. And again, Ken will share more about the quantitative tool, the quantitative scale, as well as how we developed it and what we've learned during the validation process. So next I will turn it over to Yvonne Jostin, who again leads our community engagement studio team.
Yes, thanks, Consuelo. Can you hear me?
Yes.
Okay, good. I didn't know if I was still muted. So just a little background about the community engagement studio model, which we started testing here through the Meharry-Vanderbilt Community Engagement Research Corps about 9 years ago. So over that time, we've had a lot of community and researcher input and a lot of tweaking and testing of the model. But what we have today is it's a consultative model of engagement. It's generally a one-time only meeting where researchers can get input from the people that represent their population of interest. So it's definitely not CBPR. It wasn't meant to be. We were intending to really reach or meet researchers where they are in terms of their knowledge and experience of community engagement. So this model is ideal for clinical and translational researchers who really have not had a lot of exposure to community engagement, but it's an excellent way for them to get input on their research. There is an expert panel that is created for each studio, so it's not a standing board. The expert panel, it's usually 8 to 10 people, again representing the researchers' population of interest, and as Consuelo said, for this project, over 20 studios, there were 153 individuals who participated as experts. This was a very, very diverse group in terms of racial and ethnic background, age, socioeconomic status, etc. Many of our experts have participated in multiple studios, depending on the request of the researcher. And we currently have an expert pool of about 400 people that we can call on for studios as they are requested. The experts are not research subjects. They are consultants, and we do compensate them for their time. The process after the researcher requests the studio, typically we will sit down with the researcher and talk about who really needs to be at the table, what's the takeaway, what do they need out of it, whether it's informing a grant proposal or looking at some issues at a research project that is underway. The researcher prepares a brief presentation. We provide a template of no more than 10 slides. A lot of times we will actually go back and edit the slides so that they're more, they're in layman's terms. And we do, typically we'll do some coaching with the researcher in terms of communicating their science in layman's terms to non-researchers. The meeting itself is usually about an hour and a half to 2 hours. We focus on 2 or 3 main questions. Any more than that is really too much. There is a community facilitator. We really encourage the use of a community member to be the facilitator as a way of really sort of balancing the power in the room. This is something that we're very aware of, sort of the natural disparity when you bring researchers with multiple degrees and authority into a room with people who are not researchers and don't necessarily consider themselves to be experts. Typically, our best community facilitators, including Yolanda Vaughn, who is part of this research team, have a community organizing background. We take very detailed notes, which is what the product that we give to the researcher after the studio. We don't record, and typically we don't record and transcribe the session because, as I mentioned before, the experts are not research subjects, so this is not research, this is consultation. And so we don't provide the transcripts. We don't want our researchers to feel tempted to qualitatively analyze the data for their scholarly product. But in the case of this research project that we're talking about today, we did that. The notes will include comments, but also we pull out specific recommendations that the community experts make. And these are used to typically inform the development of a proposal or address challenges of an ongoing project, such as overcoming barriers to participation. So next slide, next speaker.
So next slide.
Okay. So in our analytical project, what we were trying to do is compare the content of translational studios to community engagement studios. And we haven't talked yet about what translational studios are, have we, in detail? So I'll just mention that a translational studio is a more traditional research studio meeting that is facilitated by the university to assist investigators in preparing grant proposals or refining research methodologies and protocols and implementation plans. And so that's a very short summary of what a traditional translational studio is. But typically, what is done is scientists from the university are brought in to provide advice to the researcher. And so we're comparing those types of studios to community engagement studios in this project. And so in order to do this comparison, we needed to examine the text data from the transcripts of the two types of studios. And so what we did was we used a qualitative method and coded those transcripts. And so coding takes place by reading the the actual text and creating and labeling excerpts within the text. And so an example I included is in the transcript, a participant said this is in a community engagement studio where they were getting input on the idea of creating an app for patients to use. And so the participant says, so you would have some kind of orientation to walk a patient through how to use this app before they left the hospital or your office. So that was some input from a participant. And so that was labeled ethics, and it was labeled education of group or community. And so using this method and multiple coders, including all types of participants from the project, qualitative analysts and patient advisors, we coded this data. And so again, the goal is to compare what are we seeing in the translational studios and what are we seeing in the community studios. And so I'll show you our data on this that we have so far. Can we go to the next slide? So this gives you a feeling for what we're seeing in the two different types of studios. And so as we go through and code the text data, we are identifying these categories. And so down the left side, you see the categories: research design, quality improvement, methods and protocol, etc. Some of these categories are very traditional research design categories, things like the research population, the methods and protocol, defining the population, etc. And so what we found was that in the community engagement studios, we were seeing input on those traditional research design topics, such as methods and protocol and defining the research population, but they were also giving input on topics that the investigators don't traditionally get from fellow scientists. So things like trust and cultural appropriateness of and selection of patient-centered tools. And so these are things that were almost unique to the community engagement studios. And so in addition to giving more traditionally classified research input, they were also giving input on these other new categories. And so the other thing that came out that was really interesting was that was the form of input. So in the translational studios, there was a predictable type of interaction between the investigator, the researcher, and the other scientists in the room. And in the community engagement studio, we saw a lot more interaction in the form of storytelling. And we found this interesting, and we're looking at that at the content of those stories and the way those stories are told, and also looking at the way that the investigators responded to those stories, because the investigators are trying to then translate the information in the stories back into the categories that they need to write their proposal or whatever it is that they're trying to do. And so this has been a very interesting aspect of the project. Okay.
Okay, my task is to quickly walk you through the development and validation of this new quantitative tool that we have, the purpose of which originally was set out to assess the patient-centeredness of research, and by the time we got through developing it, we now see that it really is one that is used for assessing the person-centeredness of research. And the subtle difference there is that we realize that all patients are persons, but it's also the case that there are lots of persons out there who are involved in research who aren't necessarily patients. And so by calling it a person-centeredness approach, we cover the waterfront. It's broader than just patients, but it clearly can be used for patient and health related, but it can be used for other kinds of research also. The purpose of the scale, of the rating scale, is to assess the person or patient centeredness of research products. An abstract is an example of a product, a manuscript, a proposal. It could be something, a part of a proposal like a consent form. It could be a video or an audio recording, or as we've just heard with the studios and the qualitative thing, it could be transcriptions of recordings or videos. So it's broad, but in terms of the kinds of products that it can be used with. The scale was initially developed by Dr. Wilkins and the team using all of their experience and expertise that they had over the years in doing community-based research and patient-involved research. The initial tool consisted of 11 items in the form of questions. There was a 4-point ordinal rating scale given to this, and you're going to see a little bit later a picture of the latest scale. We're not going to show you the original version, but we did a study based on that original version just to get some sense as to how it was operating and was it good enough for our purposes. And the initial validation study, what we did is we chose 60 research abstracts that had been submitted to one of two kinds of meetings, and we had those abstracts independently rated by 2 raters each. So the 2 raters rated, well, there were a whole bunch of raters, but each abstract was rated by 2 raters. 30 of those abstracts had been originally submitted to a PCORI-sponsored, patient-centered type of research meeting, and the other 30 abstracts were submitted to a more traditional, if you wish, translational research meeting. Some of those could have been person or patient-centered research projects, but they didn't need to be, and some of those, many of those weren't. And our idea was, could our rating scale be used to separate these 2 groups of research abstracts? We had a bunch of academic and community stakeholders to rate, each one rated about 8 of those abstracts. And when the data came in and we took a look at it, we realized a couple of things that were very important. Number one is that the 11-item scale did an excellent job of separating out the 2 groups of abstracts. There was hardly any overlap, in fact, with the rating scale between the abstracts that were submitted to the patient-centered meeting versus the ones submitted to the translational meeting. And we also did a measure of the internal consistency among those 11 items on the scale, and we found that the Chromebox Alpha, which is the measure we used for internal consistency, was very, very high. It was above 0.90. In fact, it was so high that we saw that the items were fairly redundant of one another. And in fact, one member of our research team even took a look at the data and said, we can ask any one of these questions probably and get at what we wanted, which possibly is very true. But it wasn't possible, the way we did this study, to assess inter-rater reliability, because we only had 2 raters and not each rater rated the same abstracts. We only had 2 raters for each abstract, but different raters rated different abstracts, and it just wasn't set up to do that. After the first validation study, we got a lot of feedback, both from the quantitative data that came in, but also we asked all of the raters to give us qualitative feedback about the experience. And a goodly number of the raters told us a lot. And if we go to the next slide, you'll see on the left-hand side of this slide, we came up with, after all of that feedback, we came up with the new version. This is the latest version of the scale. We're calling it now a person-centered scale to assess the person-centeredness of research studies. It's assessing person-centeredness, not specifically necessarily patient-centeredness. We reduced the number of questions down to 7 using both a combination of the quantitative data that we got in from the first study, but also the team did a close look at the content and picked those 7 items that we thought gave us enough content that it has plenty of content validity to what we're asking about. And based upon a couple of feedbacks from the raters, we decided instead of using an even number of response alternatives to go to a more traditional Likert response scale with an opportunity for somebody to say essentially that they neither agreed nor disagree that this particular element is present in that particular product. So we know that raters like to have that kind of an opportunity, and the first version didn't give it to them. So here we have this new scale based upon the feedback from the original one. It was about a month ago, and we're saying, do we need to do any more on this? And I said, yes, we really need to do another validation study, but our time is running out, and we don't really have time to get a lot more in the term of products. But we developed this second validation study, which is actually 2 studies in one. We took 40 of the original 60 abstracts that we had rated. We lopped off the 2 ends of the extreme. So we got rid of the ones that were, in the judgment of the initial reviewers, had nothing to do with patient-centeredness. And we also got rid of the high end of the scale that was totally sort of patient-centeredness and worked in the middle. We chose 40 of those abstracts. We also went out and recruited 2 teams of 6 raters each. On each team we had 3 members from the community and 3 from academia, the academic community in this case, to do the ratings. And each team rated 20 abstracts. And each team got a combination of abstracts that had been initially sent to either the patient-centered or the transitional meeting, but they were all blinded as to which was which. And the data came in about a week ago from all of these raters. We've done some initial analysis. I'm going to share some of those results. I want to do a shout out to Mackenzie Houston on our team, who's done amazing work putting all this data together for us. On the left-hand side of this graph, you'll see the results from Team 1, and on the right-hand side, you'll see the results from Team 2. The Team 1 data that you see, the picture of the Team 1 data, looks like we had sort of initially expected the data to look like and hoped that it would look like. The data on the other side from Team 2 doesn't look quite the same, but it actually has the same kind of conclusion because of the fact that everything was sort of randomized. It turned out that in the abstracts sent to the reviewers on Team 2, there was more person-centeredness in that group of abstracts. But the light-colored bars represent the abstracts that were submitted to the translational meeting, and the darker blue bars, or they may show up as dark black or gray bars, represent the ones that were originally submitted to the patient-centered or person-centered meeting. The higher on the rating scale, the higher up, the higher the average rating was given to person-centeredness. That midline there is something that would be neither person-centered or not person-centered. So you see that in Team 1, the preponderance of the bars are below the line. There's a few things that had been submitted to a patient-centered meeting that weren't judged to be all that patient-centered, but most of the ones that are there were patient-centered. And on the right-hand side for Team 2, totally different group of abstracts, totally different group of reviewers. We got essentially the same finding that the person-centeredness, these ones that went to the patient-centered meeting were rated much higher in person-centeredness than the ones that went to the traditional thing. So we think on that basis, we've validated using a known groups validation technique the fact that the scale can distinguish between person-centered and non-person-centered abstracts. We're working on still analyzing the data for reliability. Those data will be in within a week or so, but we are very confident that this particular scale in this version works fine. And so we're ready to put it out today. You're hearing about it for the first time.
So we wanted to, given the degree of involvement from the community, we wanted to make sure that you heard from our stakeholder investigators on the team. So Yolanda and Al.
My name is Yolanda, and I have served as a community stakeholder and wanted to just give you all a glimpse into how we became partners with this project and what my role has looked like during that time. I'm with an organization locally called the Neighborhoods Resource Center, and at the Neighborhoods Resource Center, our goal is to equip residents and neighborhood organizations with the tools they need to effectively lead their neighborhoods. We've been in partnership with the Meharry-Vanderbilt Community Engaged Research Corps for about 5 years. This partnership was initially formed to assist the CERC with educating community about research and getting community members engaged in research activities at all levels. My unique relationship at that time was as a neighborhood organizer, put me in the position to help build trust between the local academic institutions and the community at large. And so that's how I came on to this project as a community stakeholder. But what made me personally interested in what was happening here is that in addition to my role at NRC, I've been a community studio facilitator for Vanderbilt University for about 8 years. And in this role, I had a first-hand opportunity to see how community input was being received by researchers and how that information was being used to shape many research projects. I was familiar with the community studio model, but I wasn't as familiar with the translational model and how information gathered in those studios were being used to shape research. And so when this opportunity came along to measure the impact of both the community input and the translational studio model, I was very intrigued. I had been involved in community studios, and I felt there was value in them through my observations, but I wanted to know, were we really helping research? Were we really making an impact? Were we using the expertise of community to change how research was being done and how that was translating into helping care be improved in healthcare overall? And this project allowed me to find out, or at least get a glimpse into that. So I said yes. How would I describe my role or experience on this project? I'd say it was needed. During this time, I've helped to create the protocols for interviewing stakeholders and researchers. I interviewed 2 of the academic researchers. I sat in on a translational studio, so I had the opportunity to figure out what was happening on the other side of the wall. I helped design the areas of impact for the patient engagement assessment tool. I also helped to create the person-centered research scale, as well as learn how to do some coding. I learned about an app or software called Deduce. And what I want to say is that what I didn't know how to do, the other members of the team really embraced Al and myself, and they taught us and made sure that we were equipped and felt comfortable in sharing our ideas and thoughts about the project. Some ideas I had were incorporated and some were not, but there was always good discussion about what we were doing and why it was valued or why it could or couldn't be used. And so I found value in that project. And so as a non-researcher, I never felt that my input or my ideas weren't valued, and I think that's important in projects like this. I believe that well-conducted research benefits us all, whether we're a patient, whether we're a patient caregiver. At some point in time, all of us see a doctor. We all have issues that will affect our health. And in order to build the capacity of community organizations and community leaders, we need to demonstrate the value of engagement through the community studio model as well as the translational model. And so I believe that through this project, I've had the opportunity to do that, to help build new relationships with researchers and to gain new skills that I'll be able to transfer into the next research project, and have had an insight into research that I'll be able to go out and share with the community in hopes of helping them understand the value of them participating in research, not just from a clinical trials aspect, but letting them know that their voice is important. And at this time, I'll let Al share his experience.
Well, thank you, Yvonne. I wanted to just also say that there is an opportunity for you to share your questions, and so you can type those in to the chat box, but you can also share them later on. But we would certainly encourage you to type those questions in. So I wanted to just add that this work has been extremely important for me as the Executive Director of Community Campus Partnerships for Health. We have a PCORI funded project around facilitating patient and stakeholder engagement. And I believe that what this has really done is provided me with an opportunity to really kind of get into this work in such a way that we can begin to really measure the efficacy of patient-centered engagement. So in addition to what you've already heard in terms of how stakeholders have been engaged, my overall work has been that of serving as a consultant in the design, the planning, and the implementation of the project. I've actively been engaged in participating routinely in team meetings, and these have been over the phone, conference calls, as well as have traveled to Nashville from North Carolina and other areas to attend annual team retreats. I want to just kind of focus on, though, why I think this work is so valuable. And first of all, in that it provides a framework for measuring person-centered research. And so you've heard earlier that we've kind of moved away from just talking about specifically patient-centered, but person-centered. And then also, as I've traveled across the country, I've heard so many people excited about studios. And so what I believe is that this work has allowed us to further refine how studios can serve as a process for what I call rapid cycle feedback from stakeholders who are engaged in research. And so I think that there are a number of platforms that currently exist, but this is yet another tool, if you will, in helping us to convene settings to receive very important feedback from stakeholders. And those stakeholders will include patients, consumers, and community residents. So I think that as we continue to further refine this work, the studios will become a more broadly used platform to engage key stakeholders in research. Next presenter.
Thanks so much, Yolanda and Al. It's really been great to have you on the team. I'll conclude quickly, and it looks like we have some questions already, so I want to make sure we have time for those. But in general, I would say, to our knowledge, this is the first study to really demonstrate the patient or person-centeredness of stakeholder input in a head-to-head comparison. It's one of the challenges is that typically input from the community or patients is not sought in the same way that we seek input from researchers. And so the two different studio models allow us to do this head-to-head blinded comparison. And of course, in the process, we found that stakeholders provide, input that's really aligned very much with what we get from researchers in those areas, but they also provide really unique types of input, including about things like patient-centered tools and trust and recruitment, which is really, I think, evidence of value of engaging patients and community members. Certainly, as Al said, supports the use of the community engagement studio. It's a consultative model. It's not, it's not a very intensive or resource intensive process. So it's something that we were able to do for 20 different research projects over the course of the study. I think many people are excited about having a quantitative scale. We've gotten lots of questions and inquiries about that already, and we hope that people will use it and help us to test it with other research products. We'll be refining. We've already gotten some feedback from experts in the field about tweaking some of the language and the instructions. So we hope to release that really shortly. And again, I would emphasize that Al and Yolanda were involved, deeply involved, but we engaged more than 160 stakeholders in doing things that some people think that stakeholders can't do, like rating the abstracts. And our early look at those numbers, it appears that the community and the academic raters are about the same as far as how they score. So that's also exciting that stakeholders can use this new tool. And certainly, as we've talked already, more than 150 of them served as consultants in providing input in the Community Engagement Studio. And again, we're really excited to share the new scale and as well as the taxonomy, and hope that this will help standardize some of the approaches to assessing the impact of stakeholder engagement. And then I think the last slide I have is just a final shout out to the team. You saw some of our pictures earlier, and I think we've said everyone's name, and I certainly want to again acknowledge the primary funding for this project is from PCORI Methods Award, and it's also supported because the translational studios were not paid for by the PCORI Award by our Vanderbilt Institute for Clinical and Translational Research, which is our local CTSA, as well as our Meharry Translational Research Center, funded by NIMHD, and that's metric. So I think we'll move to the chat box for, looks like a lot of questions, and Yvonne might be answering some of them. So let's see, who's first there? Oh, Lloyd. Hi, Lloyd. How does the revised rating scale compare to the PCORI review criteria? They appear rather similar. Actually, great question, Lloyd. And Mackenzie, I don't know if you want to unmute Lloyd if he has a follow-up. But the initial items in the scale actually were heavily influenced by the PCORI criteria. So I think that PCORI had done a great job of trying to help us understand what patient-centeredness is. So we did pull from those criteria when we developed the items.
Answered my question, and what beautiful work. Thank you.
Thanks, Lloyd. And then how are community experts for the Community Engagement Studio groups recruited? Yvonne, it looks like you've answered that. Do you want to say something else about it? I might have to unmute.
Yeah, so we really rely on our community connections. Tiffany Israel, who's part of the studio team but also part of this research team, and I both came from the community and had a lot of relationships that we had established. As I think many of you on the call probably are familiar with sort of the boundary spanner role of a community navigator. So we would actually reach out to people we knew in these community-based organizations to identify people that would be interested in serving in these consultative roles. We really made an effort not to reach out within the university community. We wanted people that were, for the most part, somewhat research agnostic, I guess is the term. Occasionally, we recruit within the clinical setting at the university because the research population of interest may be a very, very finite population of patients, but generally we are not working with people that have a previous relationship.
Thanks, Yvonne. And then there was a follow-up question related. Did all community experts have a previous relationship working with the university? And you may have answered that already, but I'll quickly say no, that many of the participants or the community engagement studio experts don't have a relationship, although once they have participated in the community engagement studio, they can agree to be contacted again, and quite a few of them actually serve in more than one studio when we ask them. So.
Yes, and I would add that we also have reached out through social media, through community listservs, support groups that we can find online, and we've actually recruited for studios in other cities using the same method. So a lot of it has to do with how you finding the right person to ask and how you approach them.
Yes, and I'll answer quickly to, there was a question about the slides being available. They will be, as well as the recording. And Kate, hi, we will share the instrument. We have a little bit more refining of it to do, but when you see the slides, you'll have a sense of it. But it'll probably be another month or so before we have the final instructions, the wording, as well as scoring. But we will certainly make that available. And then there's a question about the decision to move from patient-centered to person-centered. So Mackenzie, can you go back to the slide with the scale? Ken mentioned this already. I don't know if you want to take the question, Ken, but we did find that feedback, and if you look at the wording, you'll see in some cases we say patients or community members, and that's because for some of the research in the abstracts that we reviewed, the work was not about a patient. It might be about a community that's healthy, or a geographic community, or a group of people who identify by a demographic such as race, ethnicity, or they might be sexual and gender minorities. And so these people don't necessarily identify as patients, and we thought that, as Ken mentioned, person was more encompassing than patient.
Yeah. I was thinking about this actual question this morning and hoping that somebody would ask about this, so I'm glad that it's been asked. Both Consuelo and I are involved in an initiative that some of you in the audience may have heard about, but the rest of you will hear about very soon. And it started off being called the Precision Medicine Initiative that President Obama started, and NIH is funded for at least the next 10 years. And it's kicking off this month, but it's going to be called All of Us. And we're going to, this initiative is going to recruit over 1 million individuals, citizens of the United States, as diverse as our population is, and try to do that. The one thing that we're not recruiting specifically, though, is the fact that they have to be patients. Probably most of them will be patients, but that's not the way in which you get into this All of Us study. And it's a great example of how what we're trying to do is to understand health, but from the perspective of the whole person. And precision medicine used to be called personal medicine, and the importance is, if you want to study the whole person and how the whole person affects health and health affects the whole person, you need to get out of the patient role and into the whole role. So calling this a person-centered scale as opposed to a patient-centered scale, I think, is in line with that philosophy.
Thanks, Ken. From Thelma, hi Thelma. The final question on the revised scale combines multiple categories. Did the prior version explore each item separately, and if so, were they equivalent? Is Thelma unmuted? She might have a follow-up to that. So we're looking at item 7, Thelma, and I'd love to hear the multiple categories you see there, unless you're talking about the different types or how people might participate, but I'll tell you how I see the question. It's really, or the item is intended to assess whether or not the researchers or the research product has any evidence that stakeholders were engaged. And so we don't quantify how they were engaged, and certainly we're talking about different, perhaps, intensities of engagement might be represented by an advisor versus consultant versus team member, but we really wanted to get at whether or not there's evidence in this research of engaging stakeholders. Do you want to follow up, Thelma? We don't have you muted, so Thelma, check and see if you muted yourself or if you're still on.
Okay, can you hear me now?
Yes, we can hear you.
So my interest was in terms of the intensity, because depending upon the project and the depending upon the type of project and the potential barriers or facilitators, to really having a project that's well adapted and a tight fit with the community, the roles, simply having a stakeholder, an advisor, consultant, or team member there may not represent the critical factor for acceptance and uptake and adoption of the study into the community. There may be different types of interactions that are really important at each of those levels. So that's why I posed that particular question.
Yeah. No, that's a great point, and I absolutely agree with you. This scale will assess the degree or intensity of involvement. You do have a little bit of an opportunity to express that with the somewhat agree and strongly agree, but it's obviously a very narrow there. But otherwise, well, we're not able to assess that specifically. So thanks for pointing that out.
And if I might jump on that one also, even though we're calling this a quantitative tool, and it is because you can get a number out of it and so forth, it doesn't mean that if somebody uses this tool, they can't also ask for qualitative responses to elaborate upon the quantitative thing, so that it would be totally possible, whether you're administering this online or in a person-to-person paper and pencil kind of thing, to ask for and solicit qualitative, open-ended comments to any of these particular items, and so somebody can explain a little further why they checked off whatever they checked off for that particular item.
Yeah, I like the tool, and thank you.
Thanks, Thelma. And we have a question. Can you speak a little more about the decision to have a community engagement studio once as opposed to an ongoing process to advise? Amy, we typically think of the community engagement studio model as a discrete opportunity to get a consultation from community to help solve a problem. Often what is recommended, though, is that for studies that really truly intend to involve communities or patients, typically one of the recommendations is that they have a process in place for ongoing involvement, such as adding community or stakeholders to the team, forming an advisory board. I don't know, Yolanda or Yvonne, if you want to add more to that.
Yvonne?
Yeah, this is Yvonne. So as I said earlier, this model is really very helpful for clinical and translational researchers who have not had experience or training in community engagement. Certainly for someone who does CBPR, this is really not necessary because they have the skills and the infrastructure in place to engage community members throughout their work. But it's kind of a first step into the world of patient and community engagement for many researchers. And I think Consuelo mentioned that a lot of our experts go on, well, the researchers will come back later and say, well, I got the grant, I need to set up an advisory council. Can we go back to the people that were in the studio and see if anyone's interested? So it is, like I said, it's kind of a first step, a toe in the water, you might say, of patient and community engagement that hopefully will lead to other engagement activities for the researcher.
I think this will have to be our last question as we're nearly out of time. Since this is a quest for shared knowledge between academia and community, how does the person of the academic participant integrate into the person-centered approach? Caroline, it looks like you're not able to speak. You don't have a microphone, and I'm actually not sure if I understand your question. But I think if you were asking how person-centered are these approaches, for our project, I would say that we didn't, it's disease agnostic, it's a method, and we certainly did our very best to engage stakeholders at every step of the way. We consistently looked at each step on how we would actually engage community members or patients, and if they weren't engaged, why weren't they engaged. For the research products that we intend to rate, or that these tools might rate or help analyze, I think that's something that hopefully the taxonomy and the scale will help us to determine. But I'm not sure if I'm answering your question. So if you want to type something in to follow up to help us clarify. From the community point of view, why are you interested in my health? How is this work part of your academic person? Interesting. Anybody else want to take that one?
I also am not exactly sure where you're getting at that, because I have a hard time separating the, as an academic and as a member of the community and the whole construct of health. They all seem to sort of work together in some interactive, synergistic kind of way. It's hard to sort of separate it out, but I'm not sure if that's what you're driving at. But thank you for the question anyway, and if anybody else in the audience thinks that they may have an answer, they can type one up. We'll share it with everybody.
And we're happy to follow up offline if we didn't get to answer your question. And also, if others have questions that we didn't get to or didn't get to open the microphone, especially if you're on the phone, I'm sorry if we didn't get to answer your question. I think we're about out of time, and really want to thank everyone for joining us. And we have on the screen, and is it in the chat box as well, a link for an evaluation you can share with us. What you thought, how we can improve this, and certainly I'm sure that CCPH would appreciate the feedback. Al, would you like to end? It looks like maybe we lost Al, but thanks again to Community Campus Partnerships for Health. Thanks to the fantastic team, and we'll look forward to sharing our work, and you can visit our website. Thank you.
Take care.
There we go.
Thank you.